Today I am going to present a case on ultra low contrast Cto Pci. This has been done with my mentor Dr. Sharath Reddy. Coming to the case, the history, here is a patient of around 67-year-old male who has presented with chest discomfort and complete heart block in the year 2019. Then angiogram has been done which revealed single vessel disease, and pacemaker implantation has been done in the present period of around 2019. Then he has again turned up in around 2022 February 15, for which angiogram has been done which revealed single vessel disease in the RCA, and he was planned for PTCA. He was declined due to some other financial constraints. Then the risk factors were like he was diabetic, hypertensive, and diabetic nephropathy, for which his creatinine was around 3.73 and EGFR of around 17 ml. On 2D echo, it showed global hypokinesia with moderate LV dysfunction of EF around 38%, mild MR, mild TR with moderate PH. And we have been planned for IVS guided PTCA to RCS. Coming to the angiogram, which has been shown like in AP caudal view, in which there is LM is insignificant, LAD and LCX are also insignificant with retrograde filling into the RCA, and in LAO caudal view also, which shows the insignificant decrease in the left system with retrograde filling into the RCA. And in AP cranial view, we can see a very good septals with retrograde filling into the RCA, and RCA coming to the right system, there is a total occlusion in the RCA. And for planning of the angioplasty for this patient, for which we have started with EBU 3.5, we have took and we have been wide into the LAD, and the IVAS has been done. First we have identified the septal collaterals, and septal collateral injection has been given to identify which retrograde collateral is the best for the retrograde entry. Then the retrograde wire has been kept at the distal cap and retrograde microcatheter into the RCA. We have took the wire of around cyan blue with caravel microcatheter support, and we have been placed at the retrograde space as a distal at the distal cap as a marker. And we have been taken in both the views of LAO and RAO view. And again, for antigrade wiring, we have been taken AL 0.75. And initially, we have been started with cyan blue wire, and the wire has been changed from cyan blue to Gaia 2 wires. And the marker entry, we have been confirmed in both the views from LAO and RAO view. And after the wire has been passed to the total occlusion, we have been changed the wire from Gaia 2 to again Varcos cyan blue wire, and granuloplasty has been done. After wire passing to the total occlusion, we have after pre-dilatation, we have done IVAS showing areas of around at the B6, the intima area diameters of around 2.96 and 3.3 at the B6, and at B4 the areas of intima of around 1.9 and 2.3 for intima, and 3.4 and 3.6 for EEM, and of around 62% plaque content. And at the area of around B3, the intima areas were 2.48 and 2.7 for intima, and 3.25 and 3.34 with for EEM, and plaque content of around 38%. And the area we have been measured from B6 to B3, the length of around 46 mm. And we have been planned for a stent of around 2.75 into 48. Then the stent has been placed in RCA with of around 2.75 into 48. And after stenting, we have been post-dilated the stent with 2.75 in, distally, and 3 NC balloon proximally. After post-stenting, the IVAS result, we have been taken the areas we have got around 7.65 and 7.10 and 4.12 and 8.37, which the areas have been increased from the tight lesion, which were around 3 and 4 in previous IVAS results. Then post-stenting, a final LAD IVAS has been done for which to confirm that LAZ was not injured. This was a distal LAD showing no significant disease. And there was a mild plaque and calcium in 5 to 7 o'clock position. And there is a mild disease and minimal plaque at 12 o'clock to 1 o'clock position, and calcium some at 8 to 11 o'clock position. And mild calcium again at 7 o'clock, 5 to 7 o'clock position, and where the LCX is joining into the LAD here. And there is no significant disease. After confirming there is no significant injury to the LAD vessel, we have completed the procedure. And coming to the take-home message, and meticulous planning CTO, it can be done with ultra low volume contrast with IVAS guidance, and retrograde marker which has been helped as knuckle retrograde wide at distal cap. It works as a marker for antigrade wire escalation without retrograde contrast injection, and contrast usage can be limited for collateral identification, and rest all steps of contrast can be replaced by IVAS.